And it's now my pleasure to introduce Dr. Morrison. Dr. Morrison graduated from the New England College of Optometry and completed a cornea and contact lens residency at SUNY College of Optometry in New York. She's a fellow of the American Academy of Optometry, a fellow of the Scleral Lens Society, and the recipient of the Bert C. and Linda M. Corwin Contact Lens Award and the Johnson & Johnson Award for Excellence in Contact Lens Patient Care. So Dr. Morrison and I are really good friends because we both specialize in specialty lenses, and something really cool is that we both were on this journey together to open up these specialty lens practices. Mine's in Las Vegas and then hers is here in Scottsdale. So it's been really fun having each other to kind of bounce ideas off of. And she's a wonderful practitioner, a great friend of mine. So please give her a warm welcome.
Thank you. All right, financial disclosures. Can you guys hear me okay? All right, thanks so much for coming out. This is so exciting to be here. What a cool event. I love when I get fed. So anytime that can happen, it's really nice. Loved Mark's lecture, realized that I haven't prescribed an anti-inflammatory in a very long time. He would probably be very disappointed in me, but we're going to move into talking about scleral lenses and using those for your dry eye patients. And what I really want to discuss more than anything is just like in your practice, when you're seeing these patients and you have dry eye patients, because we live in Arizona, who are you referring for scleral lenses? Who are you fitting in scleral lenses? And who are you really not thinking that they're an option for? I want you to be able to, when a patient comes into your clinic and they're talking about certain things, to say, oh, you know what, this would actually be a really good patient for a scleral lens, and be able to offer that to them, because most patients don't even know what these lenses are. And it could be a great opportunity for you to fix a lot of their issues and have them really be in love with you. And then I have my own kind of specific tips and tricks for scleral lens fitting in patients that have dry eye, and very specific fitting techniques and design techniques for patients that have different types of dry eye as well. And so let's talk about how you can achieve your best results when you're doing these scleral lenses. So why do I care about scleral lenses? Well, I actually always have. From 7th grade until I was about 27 and graduated from optometry school, I was unable to wear contact lenses at all. I had really bad GPC as a young kid. I was in soft contacts dailies, orthokeratology, RGPs, and then finally in optometry school, when scleral lenses were getting popular again, I was fit in scleral lenses, the original ones with spherical haptics. And again, those didn't fit me, so I was unable to wear them. And so I was kind of on this journey for really myself, just to find something that would work for me. I didn't want to wear glasses all the time. Glasses when I was really young were not as cool as they are now, and chic and hip. And so I really wanted to get back into contact lenses. And so when I moved back to Arizona from New York, I was like, this is a great time to just open this specialty contact lens practice and be able to help patients that are like me, who really have never been able to successfully wear contact lenses at all. Oh, and that's my dog and baby and husband who's sitting right there. He's an optometrist as well. And types of dry eye patients. So let's begin with just what are the types of dry eye patients in your practice, and when are you thinking about scleral lenses versus not thinking about scleral lenses? So the first type is aqueous deficient dry eye. And this could be as easy as, someone who has inflammation, and that inflammation is making their accessory lacrimal glands not help create tears as much, and could be as severe as someone with Sjogren syndrome, or a really, really bad inflammatory systemic disease that's really affecting their ability to produce tears. So you see these patients and you're kind of ruling things out. Their meibomian glands might look okay. Or they might say, like, I have Sjogren syndrome, but they're not telling you that they have dry eyes. They might be like, oh, I have Sjogren syndrome, but the dry eye is not that bad. Sometimes it is, sometimes it's not. Are you thinking about scleral lenses for those patients? So I would say if it's a general inflammatory based dry eye, try all the other stuff that Mark was talking about first. So try to take down the inflammation, try to supplement the tears while you need to until they get everything kind of under control, and see if that does the trick, because a lot of times just starting patients on generalized dry eye treatment because they've never been on anything before will really help with their ability to wear soft contact lenses. But if you have somebody that has tried a lot of dry eye treatments before, they have Sjogren syndrome, they have like a Crohn's disease, different types of inflammatory based systemic diseases that are making them have dry eye, definitely recommend it. Say, if you have never been never been successful in contact lenses, then scleral lenses might be a great option for you to just replace that tear film, because a lot of the Sjogren syndrome patients, they're never going to create the tears anyways. Even if you do your best job, even if you're doing everything and they're putting in drops very religiously, they're just never going to get there. And so replacing the tear film via the scleral lens is really great option for these patients. The next type of subset is evaporative dry eye, which, as Mark was saying, was kind of the type of dry eye that we think of as more of more common. So most people have meibomian gland dysfunction, and I put a lot of these other types of systemic autoimmune diseases in here, because when you're seeing patients that have a really bad autoimmune disease, and they've had this huge acute inflammatory event, you're going to notice that the lids are really affected, because generally when you have like a graft versus host or a Stevens-Johnson syndrome, they've had this huge acute inflammatory event where their body starts attacking itself, and it attacks the mucous membranes. And so the mucous membranes start to become scarred over. They just don't, the meibomian glands start to drop out. And when you see these patients, even if they look kind of normal, if you pull down their lids, you'll really see that the meibomian glands are not even there sometimes anymore. And having options to image them are really amazing. I don't, but some people do. And that would be really interesting to see if you see a lot of these patients, to image those glands. But that's why I put it as evaporative, because when you damage all those glands, they're probably never going to come back. And so you can kind of, you can think to yourself, this patient is never going to achieve the type of oil tear film that we would want them to have. So are scleral lenses a great first line treatment for them? Yeah, I would say if you have a meibomian gland dysfunction that's, kind of normal person, they're not blinking enough, treat that first and then offer scleral lenses as like one of their later options. But if you're having somebody with this really, really bad systemic disease, I would definitely offer it as a first line treatment right away. People with Stevens-Johnson syndrome particularly a lot of times they'll have this really bad corneal scarring. And if you put the scleral lens on their eye, you actually give their eye a chance to heal. And so you'll see that the center portion of their cornea over their pupil starts to become clearer and clearer and clearer. And you're like, well, I didn't even know that was possible, because it looks really scarred over. And they'll achieve better vision with time. And sometimes it's just giving it that time to clear up. You might be thinking too, we're using scleral lenses in these cases, a lot of times it's like a Band-Aid. So soft contact lenses are also used as a Band-Aid. So soft bandage contact lenses, you've probably done it before. A person has a scratch, you put a Band-Aid contact lens over, let it heal up under. So in people with really, really bad dry eye, what's the difference between using a scleral lens kind of as that Band-Aid and just using a soft contact lens as a Band-Aid to help them heal up under the soft contact lens? So I would say that if a person has not a lot of feeling left in their cornea, they've had tons of surgeries, they don't really notice that they have dry eyes, but they keep having maybe a persistent epithelial defect, you can definitely give them a soft bandage contact lens. I used to do it all the time at my cornea practice. But if the patient is a really bad dry eye sufferer and they have just horrible ocular surface and they're very, very symptomatic, I would say scleral lens is definitely better than a soft bandage contact lens, because the scleral lens will provide them the relief. And a lot of times these patients who they've been given soft bandage contact lenses, they're like, oh, I tried that and it just kept drying up on my eye and it felt really uncomfortable, almost more uncomfortable than just letting it be. So this is definitely something to think about. This is a patient of mine. Oh, I like that the pictures turned out okay. On my computer, they looked horrible. So this on the left-hand side, this is when I first saw this patient. She has graft versus host disease, and she came to see me on referral from an ophthalmologist because she has acute myeloid leukemia, and she had a bone marrow transplant and ended up with graft versus host disease, where the bone marrow transplant graft was attacking her host tissue. So she has like kind of the typical stuff I was talking about earlier. Her body is now attacking itself, attacking the mucous membranes, and she's extremely, extremely dry, lids, huge, puffy, red. And this is her before and after a scleral lens treatment. And she's been in scleral lenses for a couple of years now. So this is probably after about 3 months of her treatment. On the left-hand side, you can see maybe that she has a lot of SPK, especially in the central cornea. So her vision wasn't very good. And then this right picture is after we had done the scleral lenses for about 3 months. And you might be thinking like, okay, well, that kind of looks weird too. It actually looks a lot better in real life. This tear surface on the front surface looks a lot better. Her SPK actually cleared up. And if you see just at the bottom, there's like these little black kind of dots. That's called epithelial bogging. Sometimes when patients wear scleral lenses for a long period of time, the epithelial cells, because they're soaking in solution, they just get larger and then it resolves when you take off the scleral. So it's not a big deal. It's just one of those things that you see. It's like soaking in a bath and then you get all pruny. That's kind of like similar. So she, interesting story about her. She came to see me, and the first consult I had with her, I didn't think she was going to show up. I thought she was a no-show because it had been 45 minutes after her appointment time and we didn't hear from her. I was like, oh, okay, I guess she's just not going to come in. And then we got a call from her in the office, and she lives in Glendale, and she was driving on the 101 trying to come and see us. And she had to pull over 4 times because her husband couldn't drive her, who usually drives her. And she was driving herself. Her eyes were so blurry, so painful, so dry that she just like didn't feel safe to drive. And so she kept pulling over, putting in drops, pulling over, putting in drops. And so this was an awesome patient to work with, because after we got her in these scleral lenses, she felt 100 times better. And she was able to drive successfully, very independent. She didn't rely on her husband anymore, which is like a huge thing for these patients, to not rely on their spouse to drive them. And so this was an awesome, awesome case. This was something that Mark touched on, which is neurotrophic keratitis. It's not really like a dry eye per se. I just kind of threw it in here because I thought it was very interesting. If you are in a cornea heavy practice, or you have a patient who maybe had herpes simplex, and the virus destroyed their corneal nerve, so they really don't have a lot of feeling left in their cornea, you could see a patient that gets these persistent epithelial defects. So cornea opens, keeps opening, and the patient will come in and they'll say, oh, like my vision is not very good and my eye's kind of irritated. And you're like looking at them like, oh my God, like you have this huge defect and it doesn't resolve. You put a bandage contact lens on, it still doesn't resolve. And you're like, why is this even happening? It's happening because they don't have any innervation left, or they have a very, very decreased innervation to their cornea. And that feedback loop to the brain saying, oh, something's wrong. Just send me extra tears, send me more, like help my limbal stem cells clear this up. It's just not there. And so they don't have that response. And so, yeah, generally this is because of herpes simplex. That's like the most common way that you'll see this. But it can also be facial surgeries that damage some of the nerves, so it innervates the cornea. Surgical procedures. A lot of patients that I saw with keratoprosthesis, they had a lot of these persistent epithelial defects because their cornea actually never heals. It just grows up to this plastic cylinder in the center of their eye. Bizarre look. I should have put a picture in here, but these are types of patients that you'll see. These patients do well with soft bandage contact lenses, again, because they don't have any feeling in their corneas. So if you want to heal up a persistent epithelial defect, you can put one of those on and put an antibiotic until it heals. But one thing that I thought was interesting was if you use a scleral lens for this, you do avoid lid insult. So the lid's going over the cornea again and again and again. And so perhaps it could heal up a little bit faster if the patient's willing to go through a scleral lens fitting. This PROS does a lot of the studies, Boston Foundation for Sight. So they did a study with PROS just showing that I took a person with a persistent epithelial defect, put a PROS scleral lens on them, and they actually wore it 24 hours to let this defect heal up, even at nighttime. Your cornea will swell up at night. That's just the way it works. But they took it out in the day, filled it back up with solution, put a fluoroquinolone drop in there just as a prophylactic so they don't get an infection, and then just replaced it. And they did that until it healed up, and then was able to remove it and resume just regular wear without the fluoroquinolone. And when I was researching this, I was like, I don't know if I would want to put something in the bowl of a lens that is not preservative free, because then the chemicals are just sitting on your eyes all day. And I learned that Vigamox is actually, they consider it self-preserved. So it's not, I guess it's preservative free in a way, but it's self-preserved, meaning that the antibiotic qualities are high enough to keep out bacteria on its own instead of using like a BAK, which would really irritate your cornea. So that was very interesting. So if you ever have to do this, just use Vigamox. Non-healing ulcer is a different story. That's a defect that just has bacteria component. I would not put a scleral lens on these patients. I wouldn't put a bandage lens on these patients, as you all know, and wouldn't do anyways. And a lot of the studies that I was looking at just showed that for persistent epithelial defects, it's safe and effective to use scleral lenses. You could even just, a lot of times with me, I use them during the day. And then at nighttime, I just have the patient like tape their lid closed. I don't really like scleral lens use at night. I do have a patient who had some brain surgeries and some facial surgeries, and she basically like cut her fifth nerve. And so she doesn't have any feeling in her eye at all. Like I could punch her in the eye. Like I don't think she'd feel anything. And this was really bad because she kept getting these defects, and then her vision would go down, and then she would actually get infections in the defect, and she'd have to go back to her ophthalmologist. So we fed her with a scleral lens, improved her vision a lot, 2200 to like 2040, which I was like, ooh, that's great. She had a lot of scarring. And then she gets less of these defects because she wears the scleral lens. And then at night, I just still have her tape it. And she did have things like gold lid weights and things. We'll talk about that in a minute. When I was first starting out in optometry, I really got neurotrophic keratitis and neuropathic keratitis confused because they sound identical to me. But neuropathic keratitis is a great option for your patients to use scleral lenses if you see them in practice. So neuropathic keratitis is kind of the opposite of neurotrophic keratitis, where neurotrophic, less corneal innervation and sensation. Neuropathic keratitis is actually like an increase in sensation. So you have nerves that are misfiring, and the patient's coming in like, oh my gosh, I'm in so much pain. And you look at them and you're like, okay, I guess, yeah, maybe you look dry, but the pain threshold that they're experiencing is really not something that you would think would be so grand. And this can come from a lot of different things, surgeries, post-LASIK, because they cut the corneal nerves and they have to regenerate. And do they regenerate correctly? Do they misfire? How are the nerves looking? And then chronic dry eye can also cause neuropathic keratitis, where they just get this abnormal amount of pain. And do scleral lenses work for these patients? So we can actually image patients with neuropathic keratitis and see that they have an increase in corneal nerve density. So you can see kind of like why they're having so much pain. And it's something that you can actually prove, as we used to think it was like all in their heads, and this is something that you can actually prove. So yes, these patients in studies really, really benefited from scleral lens use. So if you have a patient that's like in a lot of pain, they're like, oh, my dry eye, it's so painful. Yeah, give them a scleral lenses as a first line treatment option. Why not? It's worth it instead of doing a million different things and still having them feel uncomfortable. But the scleral lens, I put increase, but it was actually no change in corneal nerve density with scleral lens wear. So scleral lenses didn't do anything to the corneal nerves. They're still the same size and density that they were before, but the patient symptomatically feels a lot better, probably because they don't have the insult of the lids and the environment and the dryness all day. So it's definitely one that you'd want to recommend. I had a patient who, another interesting case, she was post LASIK. She came in to see me. One of the doctors in this room actually saw her. So we'll see if anyone knows who it is. Sounds familiar. So she's 41-year-old. She was post LASIK in 2019. I saw her in 2021. She had a lot of dryness, discomfort, pain. Mostly she was just in a lot of pain. And she was like, nothing's getting better. She was a minus 750 before LASIK. She's like a minus 150 now. So she did have some regression, but she didn't want to go through LASIK again because her eyes were already so dry. So she was just wearing glasses, and you can see that she's on a lot of treatments. She was on serum tears. She's on Cymbalta, which is just an antidepressant. It was for her depression from being in so much pain. And it was also because we use antidepressants a lot of times with neuropathic keratitis to kind of just dim the sensation of being so uncomfortable. Xiidra, Sustain ointment, Sustain drops, like every 30 minutes, Lotamax. She's another one that couldn't drive on her own. She had to have, she had a lot of discomfort. Tear breakup time was low, and she had meibomian gland dysfunction. But I do think she definitely had a huge neuropathic component to her dry eyes, because I mean, this is a lot of treatment for someone who's not receiving any results. And so what we did for her was we talked about everything. I'm going to talk about the discussions I have with patients because it's very important, their expectations. But we did scan design scleral lenses where you just take a scan of the eye and then you make a scleral lens based on that scan. And she ended up doing really well. She had a 70% improvement. She got off of a lot of her drops, which was really important to her because sometimes people think of scleral lenses as like a last line treatment because they're expensive, right? They're more expensive than a soft contact. But if you're doing serum tears and you're taking all these medications, like what's in the long term, if you're able to get rid of a lot of these medications, I think the payoff is huge, especially because the scleral lens is on a relatively normal cornea. You can keep them for a long time. She was super happy. But throughout her process, it was kind of interesting because she is one of those dry eye patients that is super hypersensitive. I mean, maybe one of the other reasons why she has neuropathic keratitis, but she's super sensitive. And so throughout the process, I would really have to talk to her. You're going to be feeling the edges of the lens. You're going to feel it more than another person. You're going to be aware of them. And, she would say, okay, I have some awareness. But we talked on the phone and I was like, listen, you can come back in. I can look at the edges and redesign them for you. Not a problem. But she was like, you know what? Let's just wait it out. My husband and I both decided that we want to just give this a real good shot. So I'm going to wait like a month before I see you again. And then we're going to come back in. And in a month, she was totally fine. I didn't need to do anything to the lens. So if you're designing scleral lenses for patients with dry eye specifically, I would really do it slowly, have them come back every couple weeks. If you put it on the eye and they're like, oh, I can feel the edges, don't redesign it right away. Just like talk them through the process because they're going to be feeling a lot more than you'll realize. This is another one of my patients to the right. She's really interesting too. Awesome lady. She had like 5 or 7 Mohs surgeries on her eyelids. So they took away a ton of tissue and they weren't able to rebuild the tissue. And I know nothing about oculoplastic, so I don't know if you can like regraft tissue. Maybe you can. I'm sure there's like some sort of way, but she had seen a lot of doctors and they told her that it was impossible to graft tissue to her eyelids. And so she was left with this exposure keratopathy. And you can see both of her eyes, lids really inflamed, exposed. And so her husband actually saw me because he has RK and he loved his scleral lenses. And he's like, oh, why don't you see my wife? She's really uncomfortable. And she came to see me and I was like, well, I can't believe you didn't see someone sooner because yeah, you're really uncomfortable. This is an intense lid condition. And she's one of those patients that doesn't really adhere to any sort of dry eye regimen. You'll give her something and she'll forget that she took it. And so I had to take a lot of copious notes and be like, oh, you really liked Avanova. And she's like, I did? I was like, yeah, no, you really thought it helped. So I'm going to get you more of that. So really taking good notes. Sometimes they forget. But exposure keratopathy can come from seventh or palsies, post-surgical procedures. We have a lot of blepharoplasties that end up with a little bit of lag ophthalmos, even a small amount can make a huge difference. And one thing that I always think is really interesting is that I worked in cornea in New York for 3 years before I moved out here. And even though I was there and I do scleral lenses and I love scleral lenses, my doctors still referred out for tarsorrhaphies very often. And I always thought that was very interesting that they, in their mind, it was still linked like exposure, tarsorrhaphy first, and then scleral lens was not even like in that train of thought. So for you to be the one that's like, hey, you can do a scleral lens for this and you don't have to have your eyelids sewn shut. For people that want aesthetics and like to look cute and, you know, not have their corner of their eyelid sewn shut, this is a great option. So I would 100% first line management, absolutely. If the person cannot close their eyelids all the way, especially post-surgery, just offer scleral lenses right away because it's going to save them time. Gold eyelid weights, it's not really super common that I've seen anymore, but I do see it periodically. Not a bad look. It's just not, you know, you can just do other things now. But I would have them tape their lids at night. So who can benefit from scleral lenses in the dry eye community? Everybody, but to different degrees. So this is my mother, and she's so cute. She's trying on her scleral. She actually was in soft multifocal contact lenses for almost like forever, GPs and then multifocals. And she has glaucoma now. And so she takes a lot of drops. And so her eyes got really, really dry. She kept telling me like, I can't see. I'm like, well, you can't see because you have like a band of SPK across your cornea, but you have to treat your glaucoma because it's relatively bad. And so we did scleral lenses for her with multifocals, and she's really, really happy. And she got good at putting them in, but at first she wasn't very good. So how do scleral lenses protect the eye in dry eye? Kind of exactly how you would think. It provides a shell, a protective shell where your cornea is no longer being constantly insulted by a shearing force of the lids, the environment, and all the things in our environment that are bothering us. Like Mark was talking about, when you close your eyes and you don't blink completely, I don't blink completely. And so it doesn't really matter if you blink completely with this. Yes, you should still blink completely because your meibomian glands have to get stimulated, X, Y, Z. But if you have a scleral lens on, it doesn't matter as much. So I have to say that I am a dry eye patient, as I told you, horrible compliance, don't do anything, should do everything, but don't do anything. And I just wear my sclerals and I feel fine. I'm probably not fine, but I haven't had an eye exam in a while. So so it prevents evaporation. So your meibomian glands don't matter as much. And then again, you can kind of manage some persistent epithelial defects, just other types of kind of craziness on the cornea, and help yourself heal under the lens. And it gives people better vision, especially with time. That's an important thing to tell scleral lens patients that are dry eye patients, is that right now your corneal surface looks bad. And right now you're seeing a certain vision, maybe 20/40, maybe 20/30, whatever. With the longer that you wear the lens, generally you give your corneal surface time to heal. And so you can actually achieve much better vision with time. So the first time you put on the lens, you might still be 20/30, but then a month from now, you're 20/25. And then you're 20/25 plus 2, and it's because your cornea has had a chance to heal. I just put this as something for everyone in this room to think about, including myself. Can you put medication treatment into the bowl of a scleral lens? I haven't heard of it being done as much. And by medication, I really mean like a steroid and, you know, another immunomodulator. You know, maybe if you have glaucoma, a glaucoma medication. We're really not doing this right now, I think, because it's probably going to make your ocular surface a lot worse, because you're going to have something sitting on the eye that's kind of toxic in a way. But something to think about. I mean, if you have really bad, some sort of disease that's really bad, maybe this could be something that could help down the road. But can you put dry eye treatment into the bowl of the lens? Well, we think, yeah, like the solution, the saline, is definitely somewhat of a treatment in a way, but it's not. The treatments, you know, would be the serum tears. And I would say mostly serum tears is something to think about because they don't have preservatives in them. So you can put them in the bowl of the lens, especially for really, really severe dry eyes. I was meeting with a doctor, a cornea specialist from Mayo the other day, and she was saying that she has a lot of ocular cicatricial pemphigoid patients, and she a lot of times has them put the serum tears in the bowl of the lens and put them on just for that extra. It stays on the eyes for longer. It can really heal you up. And I was like, oh, great. Like I'm going to be telling my patients to do that more often, especially if they still take serum tears after their scleral lenses. Why not? They usually have these big boxes of tears once they purchase them. It's like 3 months supply. Why don't use it up? Put it in your scleral lens. It's going to make it maybe a little bit cloudier, the vision, because it's a little bit cloudy of a drop. So just something to warn them about. And maybe the most important 2 slides are next, is what type of design are you thinking about when you're dealing with a dry eye patient with a scleral lens? Because they're going to have specific complaints that other patients of yours will not have. You put this lens on a patient with keratoconus, and they're like, oh, great, perfect, bye, like feel amazing. This is not going to be that patient population. People with dry eyes are very sensitive. People with very severe dry eyes are hypersensitive. And so they're going to notice the edges more. If you have edge lift, they're going to notice it right away. If it's too tight, they will also notice that. If the lens has a lot of clearance and the lens is really thick and it's sticking out far from the eye, they will also notice that. And so this is just all from my experience, but make the lens as thin as possible. Make the clearance as low as you can while still giving them kind of a range. You don't want it to be like 25 microns and then they have to get a new lens in 6 months. And generally you want the edges to be a little bit, I would say go a little bit on the tighter side. If you're going between like tight, loose, like what do I make the edges like? Just make them tighter at first, because if there's any edge lift, that patient will notice it right away and it will not get better. And the too tight and too loose edges, again, this is just from my experience. This is one of those things where it's really hard to see in clinic, unless you have obvious blanching where the lens is really tight and it's squishing the conjunctival vessels. You're going to be like, looks good to me. You can even take an OCT, looks fine. Honestly, the difference between tight and loose on an OCT also looks really good. So it's very hard to see what. So I have some tips. Okay, so here's the first tip. So when the patient's in your chair and you've let the lens settle for a little bit, put a lot of fluorescein right up here so it goes across the entire cornea. If the fluorescein seeps up under the lens, you're too loose. Even if the edges look really good, and they probably will look really good because it's really hard to see lift, if it goes right under it, you got to tighten it up. And if there's a trick you can use where you take your finger and you take the lower lid or the upper lid, just different types of the lid, parts of the lid, and you push it just really gently, kind of like on the edge of the lens. And if you can see the fluorescein going like choop, 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 under the edges of the lens, it's also too loose for these specific patients. For other patients, they don't care, it's fine. But for these patients, they will notice. And so if they're still, and again, don't change anything right away unless it's obviously horrible. Just let it ride for a little bit, see how they're reacting, because they'll come back and be like, I feel the edge here. And then you'll see the fluorescein and you'll be like, okay, I'm going to make it tighter. Tighter edges are actually, that are not too tight, are even harder to see because you put the fluorescein on top and it's not getting under. So you're like, oh, okay, I think I'm good. And there's no blanching and the OCT looks fine. And so you're like, well, how do I tell if this is too tight? Because the patient is still feeling the edges. They feel like it's like a pressure. So the way that you can do this is you just look for this specific complaint. So you say, when you put the lens on, did you notice the edges? And they'll usually say, no, when I first put it on, it feels fine. But then over the course of 2, 3, 4 hours, I can feel the edges. I'm really aware of them and it gets really uncomfortable. And that usually means that it's too tight, and just loosen it up and they'll be happy. That's a very specific thing to look for, but I've seen it in so many patients. Once you loosen up the edges, it's totally fine. And patient expectations and the discussion with dry eye patients with scleral lenses is extremely important, especially on the dispensing. So you're going to give them the lens and you're going to say, okay, here's what you're going to notice. You're going to be aware of the lens for the first 5 to 7 days. You're also maybe going to feel a lot drier in the first 5 to 7 days because your eyes are open wider and you're blinking over a piece of plastic. Overall, you will feel better with the lens than without the lens over the course of time. But in the initial, you will feel more dry. Sometimes if their edge lift is too high or too tight, they will feel drier and it won't go away. And then that you can adjust for that. They will probably have more fogging, especially the Stevens-Johnsons, those types of patients. Like you might never get rid of the fogging, but just looking at those edge lifts, the clearances, trying to decrease them, just those types of things. Sensitivity, again, the edge profile, you'd be really sensitive to it. And the patients are also going to be very particular and very sensitive in general because they've probably gone through a lot. So just walking them through the process and knowing that your staff can walk them through the process is also, I think, really awesome for them and their experience with you in your office. These are drops that I like to use with scleral lenses, and your patients will always ask, like, can I put my drops in? Yeah, they can put their drops in, you know, why not? If they're a little oily, it might muck up the lens a little bit, but if they are really married to one drop, like a Retain MGD, sure, put it in, whatever. But I usually go for these drops over the scleral lenses. I like the bottle usage because it's easier to keep in your pocket and they are still preservative free. All the other ones come in the rip-off vials and those are fine as well, but these are nice and they don't muck up the lens. BioTrue is relatively new, hyaluronic acid drop that people have been really liking. And then drop use without scleral lenses, I would keep it the same at first, but some of these patients are using drops every 30 minutes. So just don't use those drops, you know, use the other drops when your lens is on and use your oily drops, the Retain MGD, the gels at night, those types of things, just keep those. And if you have a patient that has EBMD, because you have to take off the lens at night, they're still going to have maybe a recurrence. So just tell them gel drop at night so that you don't open up your cornea at night. I have one patient with EBMD and he's a lot better now that we've started scleral lens therapy and gels, but he still occasionally has a little episode. And as you would think, like for patient outcomes, consistency is the most important thing for dry eye routines. I'm like no guru at dry eyes, definitely learned some things today. So I'm excited to take that into my practice. But I always tell patients, if you're going to do something once or twice, you might as well not do it at all. It's not going to help you. So, but if you do something every day, just work it into your routine, do it like when you're washing your face in the morning, washing your face at night, and then you can add to it. So for scleral lenses, because that's what I'm really focusing on, and most of my patients already have their dry eye management with another doctor, I'm golden. Like I don't have to do really much of anything, but I still, if they don't have anything, I do put them on a dry eye routine. I try to keep it really simple at first so they can actually do it and they don't get super overwhelmed. I don't throw the kitchen sink at them right away. And I do a lot of handouts and documents, and I put a lot of stuff on my website under my patient portal that only my patients can access. So they always have access to like exactly what they should be using. The handouts is really important for just compliance with scleral lenses in general. But if you're going to do dry eye routine with scleral lenses, just hand them something and give it to them. They can take it home. Between the latency period between when you order the lens and then when you dispense it for the first time is like 2 to 3 weeks anyways. So that's a perfect time to start a dry eye routine. So you don't have to keep them out of lenses for months and months. Just like get it started and then you can introduce it later. Does filling solution matter for inside the bowl of the scleral lens for patients with dry eye? Maybe yes, maybe no. I think it depends on the type of patient that you have. So we have our usual lens filling are Adipac, Scleral fill, Neutrophil, and Lacropure. Some people still use Purolens, but recent study was showing bacteria growing in Purolens, so we don't recommend that anymore. And Neutrophil is the only one with added electrolytes. Scleral fill, Lacropure are pH balanced, so they're closer to the pH of your tears. Adipac or Modudose, whatever you call it, is it's just not it's not pH balanced. So I mean, I use Adipac and I'm fine. I like it because it's easy to order from Amazon. Truthfully, that's like why I use it. I probably should use something different. But if you have a really severe dry eye, I generally recommend Neutrophil because patients are better on Neutrophil. And a lot of patients do notice the difference between a scleral fill and a Lacropure. I don't really know why, but I do offer all of the options to patients and say, you know, you have dry eye, I would definitely recommend this one. You can start using XYZ, but Neutrophil is a little bit more expensive. So if they want to do that, they can, but if they want to just keep it with Adipac, that's fine too. And then this was an interesting study that was done. It was basically taking people who are on non-buffered solutions, Adipac, the pink salines, and then buffered solutions, so lacquerpure, scleral fill, neutrophil, and it was comparing the two. And patients did not notice, patients who had dry eye were a lot happier with the lens than without the scleral lens in general, to the same amount between the two solutions. So they were happy no matter what. So there was no subjective difference in a person that was using a buffered versus an unbuffered in terms of their overall experience. But when they used both of them and they were asked, which one would you rather continue using? Which one did you find more comfortable? They picked the buffered solution. So the comfort value of the buffered solution was still better, even though outcomes were not statistically significant between the two, as like, oh my gosh, my lens with neutrophil feels like 10 times less dry and the other one doesn't feel as dry. It was just more of like a comfort value, and multiple studies have shown the comfort does matter. Oh, this is the pH I was just talking about. Pure lens at the bottom, don't look at that one. And yeah, for best patient outcomes, again, handouts, communication. These patients are a lot of times very, very sensitive. And so just taking that into account, they've been through a lot, like the lady who pulled over 4 times, like she needs a lot of information and talking, and like, this is what you're going to be experiencing. And we always like to do that. And then a lot of patients, if you give them a regimen of a dry eye routine, especially when they're doing like the sclerals and they're having solutions and they got to go buy everything, and they're like, well, where am I supposed to get this? It's a huge thing for them. Like, where am I going to get this? And it's a very frequent, common question. I have a links on my website, takes you right to Amazon. Boop, 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 boop. You just click on the links on Amazon. I have handouts that I give them, but I say, you can always go on my website, just click the Amazon links. They'll take you right there. You can just buy it right like directly through. So they're not like, okay, which distributor on Amazon do I get it through? Because there's like a billion Adipacs, and like, do I get the one that comes from Canada or US or whatever? And so I'm really excited that I actually got to this. Are we doing good on time? Okay, cool. So these are my cases for specific dry eye patients in my practice who are wearing scleral lenses. This first patient, he's actually my neighbor, long-time family friend. I moved last year, and so I was seeing him around, and he had these horrible red eyes, and I was like, dude, what's going on with your eyes? Like, your eyes are really red. And he was like, oh, I have really bad dry eye, and then they just get red throughout the day. And I was like, why don't you just come in and see me? Because like, maybe there's some sort of drop that you could be using. I don't know, just come and see me and I can take a look at your eyes. He has a history of Crohn's disease, so inflammatory systemic disease that he's had for a really long time. He's on medication for that, among a couple other things, but he has a long history of trying to treat the dry eye, but again, a very inconsistent patient, really didn't stick with anything. But I also think he didn't really feel a ton of relief with a lot of the things he was doing. And he's like a man in his 60s, and I feel like he just didn't have the type of compliance that maybe like a younger patient who's like, yes, I want to treat this right now would. And he also didn't feel a lot of his dryness anymore. The thing that bothered him was that his eyes got red. He probably has sort of a neurotrophic component because he's had dry eyes for such a long period of time that the nerves are just not firing the way that they used to. And so he's like, I don't really feel it. So like, why treat it? He was on Refresh like 4 times a day in both eyes. And so he comes in, he sits in my chair. I'm like, okay, good. You're here. This is his eye. I hope that you can see how bad this is from this picture. This is like one of the worst dry eyes I have ever seen. These, around the limbus, you can see it's getting hazy, and then you can see this thing over here. These are huge Salzmann's nodules. Like, I've seen some Salzmann's nodules, and these are like the biggest that I've ever seen on a person. I'm shocked that he didn't come to anybody sooner. You can see corneal neovascularization all the way around. His eyes are extremely red. I was like, man, you have bad dry eyes. We gotta fix this. And this is his other eye, not as bad, but it actually was very, very bad. It's just that the left eye, which I showed first, looked so horrible. I had to show it as my first picture. And then you can see, so this is after I fit him with a scleral and he's like has it on. And this is the OCT image. And this up here, that white portion is his Salzmann's nodule. The scleral lens is above it. You can see the clearance is too high. Obviously, we took that down. But this also right below is, it's just like a flipped iris. It's like a artifact. So he has a regular looking cornea, but that huge white portion is the big Salzmann's nodule. And this is on his right eye, and this wasn't even the worst eye. So this is like really intense. Salzmann's nodules are just an area of chronic irritation where the eye has been irritated by something for so long that it starts to develop an extra tissue, and then it develops a tissue and tissue and tissue and tissue. And then eventually you'll have these like big growths of tissue, and they're from a chronic irritation. Most of the times, I mean, that I've seen, most of the times it's dryness. And so this is like a body's mechanism to help the body. Although once you get a Salzmann's nodule, then when you're blinking over it, you're not distributing the tear film properly, and it's really irritating, and it kind of makes your dry eye worse. So it's the body trying to protect itself, but ultimately not doing a fabulous job. So we started him on some very basic dry eye treatment. Probably you guys would do a much better job than I did, because mine is very, very basic, because I'm usually focusing just on the sclerals, and he did have an ophthalmologist that had been seeing him. So I started him on Retain MGD because I was just like, let's get the oil component back on the eyes. Took him off the Refresh because he doesn't have to do both. Preservative free. I still kept him at 4 times a day because I was like, I really don't think he's going to do it any more than 4 times a day. So let's keep it simple. Warm compresses, because he did have some meibomian gland dysfunction, and he was very good about the warm compresses, and he said that this helped a lot. So I was really happy about that. And then just some omega-3 supplementation. I know there was a study that came out in like 2018 from Sinai in New York that said maybe omega-3s are not as good for dry eye as we thought, but I feel like why does it hurt you? Like they prescribe you omega-3s for basically everything in your body. Like it takes down inflammation. It does so many good things. Like what's the harm about putting them on if it's good for everything else? And then we fit him with scleral lenses. Because of those huge Salzmann's nodules, this was going to be a really tough fit. And so we did do an eye print lens, which is the mold-based scleral lens. So it could groove over those little areas. This would have been hard with conventional, not impossible, but it definitely would have been more difficult. He ultimately would have been the best with an eye print Pro, which is like the highest level of mold, but the cost was a little prohibitive for him because he'd never worn a scleral. So we put him in like the lower level mold base, which is an iFit Pro. So as you could see from my OCT picture, it probably would have been a little bit better fit if we could adjust those clearances like over the nodule and like down over other areas a little bit more aggressively, but ultimately he's doing fine. I think the only thing we ended up with was a little bit more fogging than maybe I would have liked. And I did recommend Nutrafil for him because he's one of those patients that has really bad dry eye. So Nutrafil is definitely going to help him. And so I hope this looks good. He again didn't wear the lenses as much as I would like him to because the whole compliance thing. He was like, "Oh, I wear them sometimes." And I was like, "Well, you have to please wear them every day because then I can really see if I'm doing a good job." This is his before right eye. On the left-hand side, after right eye with the scleral lens. I think it looks a lot better. I think his eye looks a lot whiter. I would like to get it looking a little bit more white than that. Nothing happened with the Salzmann's nodules. Perhaps they will decrease with time. I don't really know. Maybe not. We'll have to see. And then I think the left eye ended up looking a lot better. This was his more severe eye. Again, on the left was the before where he has a lot of corneal neovascularization. And then on the right was with the lens. And because he had the corneal neovascularization, the lens was able to provide him an environment where he wasn't constantly so inflamed and insulted and like his eyes weren't so angry. And so the blood from those vessels did start to regress. And so I considered that a definite win. So I think he looks really good. And we're going to see him because of his, again, he's not like the most compliant patient. So I think seeing him in a few months would have been a little too early. So I am going to see him in 6 months. And then at 6 months, I'll take these pictures again and hopefully they look incredible and I can put them on a next presentation and you guys are gonna be like, whoa. But for now, it's just like, okay, he looks a little bit better. He also, he did have an overall improvement in his dry eye with just a basic treatment routine, which any of you would have put him on the same thing and probably done a better job. And he liked the scleral lenses. His wife noticed that his eyes were a lot whiter. He did not notice his eyes were whiter because again, he was like, oh, I'm not really looking. And I was like, well, look, because I'm trying to do something here. But his wife did say that they were whiter and brighter. So that was a win for me. And she's a friend of the family. So I feel like she will tell me if he's doing better. He was still getting fogging under the lenses. This was something that was really hard to avoid because the clearances above those Salzmann's nodules was like 25 microns and the clearance above the rest of the cornea was maybe like 200. So it definitely varied, which it had to, and it was very difficult to get away from. I tightened the edges up as much as I could, but again, it was just something I think is going to be avoidable. I think when his dry eye gets better and he's having less epithelial sloughing, he is going to get a lot less fogging. But we did the whole Celluvisc trick where you put some drops of Celluvisc in the bowl of the lens and you fill it up with the saline, you put it back on and try to see if that'll help with the fogging. I don't know how, again, compliant he is with that, but that is something that you can offer your patients. If the fits are never going to be absolutely perfect. And it's okay if they're not. If the patient's happy and the lens is looking good, and it's not touching the eye, that's good and you're helping them. So, you know, it doesn't have to be perfect, especially in a patient like this. It's never going to be. I put the second case in here because this was a surprise. This is actually a patient that I had who is a younger keratoconic patient, corneal transplants in both eyes. And he came to me and was saying, you know, I have been wearing these scleral lenses, conventional lenses. The right eye, the vision's great, but it's really painful. And so I can't really wear it it's just the fit is not, you know, it's not very comfortable. And so I was like, okay, well, we'll see what we can do. Let me take a look at your eyes. He never made any mention of dryness. And maybe that was my fault too, because I might not have asked him. I usually ask every patient who's going into lenses if they have dryness so you can treat it beforehand, but I might not have, or he didn't say anything specific. He'd never been on a dry eye treatment before. And so he just wanted better vision and more comfort with his lenses. So we actually ended up doing, again, these patients all ended up being mold-based scleral lenses. It's not all I do, but it's just these patients that I'm presenting. We fit him with mold-based scleral lenses, and I originally had him just fill him with Adipac because I was like, oh, you're not dry, so let's just start with the Adipac and just go from there. But you do have other options if you do want them. And this is why you will see why he had to be in one of these mold-based scleral lenses. This guy had the most ectatic corneal transplant. I mean, this lens is so deep. It's probably the deepest one I did last year. And you hold it up to the light and it's like, it was crazy. And I actually put it next to a regular scleral lens because I was like, why is this so crazy? And the scleral lens, the regular scleral lens was like this big, and then his scleral lens was like this deep. And so I was like, wow, that's obviously why he wasn't comfortable. So I think anything I would have done with a conventional lens maybe would have been a difficult fit anyways. So that was really cool to see. And so he was wearing sclerals. He's happy. He can see like 20/20. He's doing great. And then he comes in for a 6-month follow-up, and I was like, whoa, something happened here. This is his eye when I first dispensed the lens on the left, and this is on the right. Like it went from red to like not red. And I always knew his eyes were a little bit red, but I didn't know it was because, you know, he'd had surgeries and he was a little irritated in general. But his other eye looked the same and it looked a lot better. So thank you so much Stephanie for having me. This was so fun. And thank you for staying. And